Good afternoon, ladies and gentlemen. So what we're looking at here are two gross specimens of distended gallbladders with accumulating gallstones, with the left specimen being cholesterol stones and the right specimen being bilirubin gallstones. So what we see here is an accumulation of precipitated solids. And of course, the diagnosis of this is cholelithiasis. So I mentioned that there are two kinds of gallstones. You have the cholesterol and you have the bilirubin. For the cholesterol ones, there are many risk factors that include Crohn's disease, cirrhosis, cholestyramine. The classic presentation of this, I apologize for any political incorrectness, I did not make this mnemonic, but remember 6 F's. The typical patient is usually going to be female, fat, I apologize for that, 40 or over, fertile, fair skin, and they'll have a family history of this disease. Remember that estrogen will result in an increase in the activity of HMG-CoA reductase, and the result of that is you're going to have an increase in cholesterol synthesis, and that can later produce cholesterol gallstones. You find that very commonly with patients who take oral contraceptives. So remember those 6 F's, and those should help you out. As for bilirubin gallstones, you're mostly going to see them a lot more in patients with cystic fibrosis and conditions that result in chronic hemolysis, such as sickle cell disease, beta thalassemia, and G6PD deficiency. So the pathogenesis of this is you're going to have a supersaturation of either cholesterol or bilirubin within the bile, or a decrease in the concentration of the phospholipids or the bile acids. Basically, you're going to need all of these to create bile. And if you have cholesterol or bilirubin that are way more than either the phospholipids or the bile acids, and you're going to get an accumulation of either the cholesterol or the bilirubin. Now, additionally, if there's an infection in the biliary tract, the bacteria there can result in deconjugation of the bilirubin, and that can result in a supersaturation of unconjugated bilirubin, which will then result in bilirubin gallstones. So the structural changes of this is mainly the precipitation of these solid masses. You can also get additional damage to the structures nearby if there is an obstruction or these gallstones manage to make it to other parts of the GI tract. You could also get metaplasia with the body's attempt to deal with that stressor. So the symptoms and signs of this are generally going to be asymptomatic patients. Most patients with cholelithiasis will not know that they have it. However, sometimes they can get pain with ingestion of a fatty meal. And if this condition progresses, which I will get to in just a little bit, it can result in more severe symptoms. Additionally, if there is obstruction of the biliary duct, you can get jaundice with that. So the investigation of this, you can find GGT and ALP if there is a biliary duct obstruction. However, the gold standard test for this is going to be ultrasound. X-rays are not generally used because bilirubin stones are generally radio-opaque and you can't see them. Yeah, you can see cholesterol stones, but overall the number one test that you're going to be looking at is going to be ultrasound. So if this condition progresses, some of the courses and complications that it can follow will result in empyema of the gallbladder. You could also get obstruction of the biliary duct, which could result in biliary colic pain, which patients usually describe as a waxing, waning pain. And that could later progress to acute cholecystitis. Now, gallstones are the number one risk factor for adenocarcinoma of the gallbladder, and that's an extremely high-yield thing to remember. Now, a fistula between the gallbladder and the ileum could result in obstruction of the small intestines. Ladies and gentlemen, thank you very much.